make the global doctor shortage disappear. The World Health Organization says that we need more than 4 million additional health providers, and we notice the shortage even here, but of course the problem is especially bad in developing countries. So we're used to looking at the world in a certain way. But if we look at the world in a different way, we can see where this physician health shortage creates, in this case, on this slide, you can see particularly obviously in the tragic skinniness of the physician supply in the continent of Africa. We can see where the physician shortage creates huge problems. And though, we can also see where a relatively new technology that first was only available to a privileged few is now, of course, becoming available to nearly everyone. So back in 2001, I had this idea about how to tackle the problem of the physician shortage by marrying it with the opportunities created by the inevitable growth of technology to create NextGenU.org, which is in essence the world's first free university, being used now in 118 countries around the world. You've heard of MOOCs, right? Massive open online courses. Well, back in 2001, MOOCs didn't exist, but the concept that since the merge of MOOCs has many educationally endearing characteristics that our courses have incorporated as well. They're free of really important barriers like place and cost, and they also reduce barriers like the time and the carbon emissions typically needed to travel to university. They also have the opportunity for great computer-based interactions, and they're globally scalable, and the only real risk to trying is the time spent on learning. But if you want to create a really great educational experience, you of course have to incorporate characteristics that traditional universities have that MOOCs don't have. Characteristics like warm and useful human interactions, the ability to customize, the ability to have a thorough assessment process, and the traditional university characteristic that most people concentrate on, NextGenU is uniquely available for credit for free for our learners around the world. And if you want to create an ideal characteristic in an educational system, it would have components that neither MOOCs nor traditional universities incorporate into their programs. For example, being available in multiple languages, or being competency-based, or having an open research policy around one's data. So we've incorporated all those characteristics into our model. Now, MOOC-style courses have traditional universities worried for two main reasons. First, because MOOCs are disrupting traditional universities' business models. And second, because MOOCs aren't subject to the same kinds of quality regulations that traditional universities are. We all know that to create a really good educational experience, you have to go a step further than MOOCs. You can't just use computer-based interactions to replace the kinds of experience provided by seeing, doing, and teaching manual skills in medicine, or through the behaviors and beliefs and cultural norms that are typically transmitted in an apprenticeship model. So we've dealt with this problem by partnering with established universities and professional societies, governments, and international organizations to provide those invaluable human interactions for our courses, our residency programs, and our continuing medical education. So I'm seeing some surprised and skeptical faces. So let me tell you about our first globally available course, which we launched in March of 2012, Emergency Medicine for Senior Medical Students. We tested this by taking all of the senior medical students in the class of 2013 at the United States Uniformed Services University of the Health Sciences and putting them through the course. And as you can already see, when you compare our students with traditionally trained students, they had essentially identical knowledge scores, even when compared with traditionally trained students at this highly resourced university. And we can see where our students also expressed a great deal of pleasure at the liberation of being able to learn anytime and any place. Same kinds of results at the University of Missouri, essentially identical knowledge scores, and our students reported particularly liking the liberation of not having to haul from some remote site to a classroom to do knowledge transfer. And at Vancouver Simon Fraser University, we piloted our first required core course for master's students in the master's program in public health, in this case, environmental and occupational health. And we found, again, essentially identical knowledge scores. And we also found much higher overall course ratings for our students than with the students in prior years' traditionally trained courses. Better results than in traditional educational institutions, even in some of North America's most resourced universities. So this kind of education includes both time spent on knowledge transfer and time spent on live, meaningful human interactions with mentors, with peers, and with patients in the case of our clinical trainings. And this kind of educational approach also simultaneously allows us to stop wasting so much precious student and teacher time and effort on gathering in one place to do knowledge transfer in a classroom, or recreating an already existing course, or getting together to set resident call schedules. These kinds of industrially deliverable educational components are all taken care of. And this fear-producing industrialization of knowledge transfer and of administrative functions liberates people to be able to perform our most wonderfully warm and irreplaceably human functions, things like mentorship or demonstrating compassion to a patient that you and I have both come to care about. And it also allows medical schools, or really any institution of higher education, to much more efficiently improve their outpouring of knowledge and of competence, to open their gates wide through these sorts of tools to anyone academically and personally prepared, regardless of their geographic or their economic place in society. And that's how we're going to solve the global health professional shortage, even in low-income countries. In fact, the most sophisticated and widest-scaled use of our model isn't being done with these emergency medicine students in the states of Maryland and Missouri. It's being done in the state of Jazeera, Sudan, where we're training the first 101 of the 10,000 family medicine residents that we're training in Sudan over the next 5 years. My colleague, Dr. Abdel Nasser, will explain a little more about the family medicine residency using the cloud-based platform that our new partner, RealDX, is providing for our residents to be able to create, peer review, and globally publish and share their own video case studies. So, Dr. Abdel Nasser.
Before we start actually this program, there were 10 family physicians in Sudan. And we organized, convinced the government to fund these 10,000 residents, and we are now having a strong tool to scale this training up with the Next Generation University. And actually, our program is a joint mission between Ministry of Health, State of Jazeera, the Faculty of Medicine, University of Jazeera, and the Ministry of Telecommunication, Health Insurance of the Jazeera State. And actually our anonymized electronic medical records together, we are able to sophisticatedly study the results of this educational revolution. And finally, we are really happy to use the platform to link this enormously expanding cohort of Sudanese family doctors to each other and to globally and to the global community of practice family medicine. Thank you.
So this Sudanese pilot is our first pilot of our first residency program, family medicine. Our second residency program is preventive medicine, and since that's my medical specialty, we have a particularly deep bench of US-based collaborators here. We're piloting the preventive medicine residency in Washington, in Texas, and in Quito, Ecuador. And as we're doing with the family medicine residency, this preventive medicine residency is being done at scale. After we do these first few pilots in these sites in the Americas, we anticipate training thousands of preventive medicine residents globally every year. And so we can up-purpose these outstanding, freely available learning objects into courses. And through the courses, up-purpose millions of smart people around the world to become the physicians and nurses, the public health workers, and really any kind of professional that the World Health Organization or any other organization or individual thinks we need. People who've had barriers of cost and of place can now fulfill their potential, each one of them providing healthier lives to thousands of people every year. And I think that this kind of generous collaboration can and should be the future of education and the future of health. A revolution that allows the world to take fuller advantage of our human potential. A revolution that's simultaneously more efficient and more humane. And I think that if this kind of educational model is widely and quickly adopted, that we could soon have an educational model that provides enough well-trained physicians to stop the world shortage. That the shortage critically globally, that the shortage of well-educated professionals could be a thing of the past. Thank you.